Good day, my dear undergraduate and emerging postgraduate students. This class, again, I'm presenting with a case history. A 15-year-old male with a long-standing history of dyspnea on exertion gradually developed a distaste for fatty foods. On examination, he was found to be jaundiced and also exhibited pain in the right hypochondrium. An ERCP was done. What is it? You people shall be telling me. And this was followed by a surgery. I hope you are able to identify the structure that is shown over here with the contents. I would like you people also to explain all this because these shall be incorporated in the permutation combination of the MCQs that we shall face. And the diagnosis is hereditary spherocytosis. The subjects covered are here, and it is for all MBBS students, not restricted to any one particular year, because we are all going to face NExT. Spherocytosis. It can be autosomal dominant or autosomal recessive. Autosomal dominant is more common, and it is basically a defect in the red cell membrane. This makes the cell less malleable, and later on it becomes more spheroidal in structure. This leads to a splenic sequestration or virtually killing in the spleen. What is the differential diagnosis? We shall be seeing, and maybe in one corner we can have that it is associated with chromosomes. What are the clinical manifestations? The patients surprisingly are young to middle age. Though it is a congenital disease, it does not manifest in the younger ages. Later on, the patient develops a moderate anemia, intermittent jaundice, cholelithiasis, a stabbing pain can be there in the right hypochondrium, splenomegaly. Leg ulcers are quite rare, more common in sickle cell anemia. This is an important diagram that I want you people to kindly remember. There is a bimolecular lipid layer enclosed between two monomolecular layers of protein. That is the cell membrane. But lower down, there is a cytoskeleton. What are we seeing over here? I am finding two pairs of spectrin. So each one is a dimer, but together they form a tetramer. Along with it, there is the 4-1. Actin is most important because the deficiency of actin is there. Because all these are all connecting to the cell membrane. At the other end, I have got ankyrin, band 3 and 4-2. This again get connected to the cell membrane. As a result of which, they are all important for the malleability of the red cell membrane, which can pass through narrow capillaries. When it is defective, they become more and more rigid. So this is given over here. I would like you people to kindly go through it. Basic cytoskeleton. And look at this one. Spectrin deficiency is a common form of dysfunction. Ankyrin also can be a dysfunction. Band 3 and band 4-2 are. After all this, it is said that ankyrin is the most common defect that is considered in a case of spherocytosis. So the red cell that we have got, you find that it is somewhat downward shape and it can bend and pass through any of the narrow capillaries. And there is a normal cytoskeleton. When there is going to be a defect in the cytoskeleton, you find that part and bits of the cell membrane are being removed so that the cell assumes a spherical shape, because that is the smallest shape that is possible or size that is possible. Normally biconcave, progressively it becomes smaller. They are trapped and devoured by the phagocytes. Now look at the cell membrane. I'm sorry, a peripheral smear. This can be given as a slide for us. I find that many of the cells, they are dark, they don't have any nucleus, they are all RBCs. But they are dark, there is no central area of pallor. Normally in an RBC, I will be seeing central pallor and then peripheral rim of hemoglobinization. These are all spherocytes. The cells are small, sometimes we call them as microspherocytes. There are some large cells again, which are more purplish. These are called the polychromatic cells or the reticulocytes. The hemoglobin anemia can be mild to moderate. And you find whenever there is going to be a destruction, there will be increased amount of hematopoiesis in the bone marrow. Peripheral blood shows spherocytes, microspherocytes. Howell-Jolly bodies. Look at this one. It is an inclusion that is seen. So it is present. Polychromatic cells, all these violetish cells. And reticulocyte count, the precursor of the RBC, can be 5 to 20 or 25% also. Normally it is 0.2 to 2%. Osmotic fragility is increased. And you can also do a red cell survival study. These are most important and routinely done. So look at the pathogenesis over here. So this is the normal shape of an RBC. Now what happens is there will be the release of this microvesicles. Now whenever there is going to be a defect in either the spectrin, ankyrin or these bands, you find that more and more of these are being released and the cell assumes a spherical shape. And it becomes more rigid also. It travels through the larger blood vessels, but when it comes to the splenic sinusoids, you find that there is stasis. Two things are very important. Because of the stasis, it can be phagocytosed. Also, because of the stasis, there can be hypoxia, lactic acidosis, again leading to cell damage. So progressively, it passes through one cycle, again comes back to the spleen, further loss of membrane, you ultimately get a spherocyte. And this is called a hemolytic anemia. Please inscribe it in your brain. And this here, are you able to see the difference between this cell and this? There is a lack of hemoglobinization, cells are dark. There can be some crisis in this, anemic crisis, repeatedly when there is going to be, or when it is going to be infected with a parvovirus, the patient can develop an aplasia also. Leg ulcers, hemolytic crisis whenever there is a repeated and increased amount of destruction. The differential diagnosis can be in burns, autoimmune hemolytic anemia, hemolytic disease of the newborn. There are also others we shall be seeing. Look at this picture. As I told you, the triggering factor can be stasis and phagocytosis, hypoxia and lactic acidosis. I'm mentioning only the words. I hope you are able to identify the spherocytes. The mean corpuscular volume is reduced because the sphere is the smallest probable shape that is possible. Reticulocytes are increased, Howell-Jolly bodies are present. And this is it. This is a normal shape of an RBC, and you find that as there is amount of stasis, these cells. So this is a splenic macrophage. The cell passes through the sinusoidal spaces which are lined by these macrophages. Part of the cell membrane are getting pinched off. So a cell that is biconcave, it becomes more oval and ultimately it becomes spherical in outline. And ultimately there can be an incomplete lysis of the cell. Also remember the lactic acidosis. So this is again a recollection for you people. This is a dimer and both put together it's a tetramer, and these are all the connecting protein. Ankyrin is most important, and more than 50% of the cases of spherocytosis, there is a deficiency of ankyrin. Spectrin is also important, but there is a large volume, about 60% has to be reduced. Memorize. And what are we seeing on the screen? This is the osmotic fragility test. Osmosis is a process wherein fluid can come inside or go outside. And fragility is the breaking of a cell. Now, what is happening over here? there are two sets of samples or one set of sample over here. So this is a suspected spherocytic sample. This is a normal sample for control. And there are series of tubes with saline of varying concentration. Now what happens in this is, look at this graph. There is a start of the hemolysis. So it starts in a case of hereditary spherocytosis much earlier at a concentration of 0.65 or 0.7. See, look at this one. At 0.68 itself, there is a hemolysis that is starting. So that is C. Whereas in a normal sample, it starts much later, 0.48. So that is what? At 0.48 it starts. So this is important for us to make a diagnosis. But a still more better method can be Eosin S maleimide method, which uses the flow cytometry to determine the amount of fluorescence. As I told you, there is a differential diagnosis for spherocytosis. It can occur in autoimmune hemolytic anemia, G6PD deficiency, snakebite, pancreatitis, and plunge. So the moral of the story is all peripheral smears showing spherocytes are not cases of hereditary spherocytosis. These are all the clinical manifestations. You can go through it. Anemia, polylithiasis, splenomegaly. Hemocirrhosis is by itself a separate topic. The iron is deposited elsewhere. Splenectomy can be a treatment. Cholecystectomy can be a treatment. Splenectomy is done because the phagocytosis can be prevented. But still, spherocytes will stay. They will be having a longer lifespan without being destroyed. Of course, supportive treatment is needed for the patient. This is the ERCP, endoscopic retrograde cholangiopancreatography. So it can go to various sites, including the bile duct, etc., take biopsies, do surgeries, so on and so forth. What are the other red cell membrane disorders? There are a few disorders, just see them. This is an elliptocyte. It is elliptical in shape. It is not spherical. Associated with 4-1 deficiency. There can be mild hemolysis, but the lifespan is normal. Osmotic fragility is also unaffected. Echinocytes are burst cells. They have got fine spicules. These are the echinocytes. They have got fine spicules found in uremia. Acanthocytosis, on the other hand, they have got sharp spicules which are uneven. They can be found in a case of pyruvate kinase deficiency, A-beta lipoproteinemia. Look at the amount of MCQs that can be devised by this. Target cells. It is otherwise called the Mexican hat appearance. So look at this one. There is a central hemoglobin and then a peripheral hemoglobin. There is also an echinocyte in this region. So this is the Mexican hat. That is why you have got that particular name. It can occur in liver diseases, thalassemia, sickle cell anemia, etc. So syntax. So these are all the headings that we people have covered. See you in what next.